The first session gave just some examples, and it's very, very important to emphasize that. There's just some of the examples of work that's currently going on in the field of women's health. But this meeting is all about broadening our perspectives. And therefore, the speakers that follow, who haven't taken the kind of traditional approach that was presented in the first session, nevertheless, in our opinion, have a very important contribution to make if our overall objective is improving the lives and health of women and girls around the world. And they've been specifically asked to come and speak about how their field could contribute to the vision that we're trying to present today. And I'd like to start off by inviting to the platform Katrina Charles from the School of Geography. And it should be fairly obvious from the first slide what she'll be talking about.
Thank you very much, and thanks for having me here today. It's really exciting to be part of this group and these discussions today. I want to talk a bit about water, so my research is on water very broadly. I'm based in the Geography Department and working, one of the programs is the REACH program, which is looking at improving water security for the poor, working in countries like Ethiopia, Kenya, and Bangladesh. And so what I want to take you through today is just a bit of an introduction to that. And particularly I'm going to focus within the water area on drinking water access. So that sector includes also relationships to sanitation and hygiene as well. And within that, what we see is women's health is often used, such as images like this, to really highlight why we need to do this work. It's so important how we can get women access to water, which is going to help them with all these health issues and other aspects. But really we know very little about the health impacts on women, which for reasons which have already been discussed today in the sex differences presentations. And we know, and there is also not much work done to differentiate the gender roles and the societal roles that women have from some of the biological health impacts in these. So I'm just going to mention a few areas in which water and women intersect in terms of women's health, that women might be options for collaborations. Broadly, the teams that I'm involved in and the teams across the Oxford Water Network are involved in lots of different areas of research that relates to health. So when we look at water and access to drinking water, women have responsibility for collecting and managing water at the household. We know that's one of their societal roles in most areas. So they carry water for long distances, resulting in musculoskeletal issues. They have often with poorly designed collection, things like the jerry cans pictured here. And this can also result in fertility issues just due to the physical burden. There's not much evidence for that. Managing water access in water scarce or contaminated sources can lead to the increased psychosocial distress. So women, as the main managers of water, have mental health issues that relate to that role in the household, particularly where there are challenges in getting access. Travelling to collect water exposes women to attacks by animals and humans. There's a strong gender-based violence aspect associated with water and water collection. And we know that certainly in times of scarcity that women may be forced to trade sex for water. And so you've got links to sexual health issues as well. One of the more recent pieces of evidence from our study is generally when we look at this access to water, we're thinking about it as a household issue. So while we talk about statistics of, I think there's 800,000 people who still don't have access to clean water at home worldwide, we're talking about a household level. When you look below the household level and look at some of the gendered inequalities, you find that women, as the managers of water, often give the best quality water to their husbands, to their children, even to the livestock first, before they'll give it to themselves. So when we're looking at the impact of water on health, we need to understand those differences in the household. We know that women have higher exposure to some diseases in certain situations because of the gendered roles they perform, so such as schistosomiasis from washing clothes in certain contexts. But what we don't know really is the sex differences in water-related diseases more broadly. There's some limited evidence that shows, for example, that girls are affected more by cognitive impairment related to poor drinking water quality, but it's very limited evidence at this stage. And it's very difficult to entangle what is gender-related and what is sex-related in that. And so I think there's a group of researchers across the university who are very interested in this work and who would be very keen to engage with you to bring water into your studies more wherever possible. So I think that was all I was going to say. Yes.
The next speaker is Sarah Harper from the Institute of Aging. Sarah, please.
Thank you very much. So I direct the Oxford Institute of Population Aging. We're basically demographers and social scientists, sociologists, social policy people. And we're interested in aging, but aging really from a societal rather than an individual point of view. But obviously, individuals make up societies and economies. We do a little bit of work on health, but we also look more at the sort of contextual variables. But over the last, I would say, decade, increasingly we've tended to look more at women and aging, and that doesn't just mean old women, but it's women across the life course in the context of aging. And we also do some work on health. So when Robin asked us to present here, we realized actually that we had 3 programs or linked projects which specifically look at women and health. And so I'm going to very quickly take you through those 3 programs and the people who are working on them. All the data I'm going to talk about is published so that you can actually get it rather than me having to explain. And then I'm going to take one program which just gives you an example of the kind of approach we take, and it is a particular project. And I have to thank my research fellow Sarah Zeller who did these slides for us. So in fact, the first one I'm going to talk about, you might be quite surprised, it's the Oxford Programme on Fertility, Education and the Environment. This is a €5 million project, which we've been doing, in fact, for just over 5 years, funded by a European foundation. And if I said we're interested in population aging, of course, we're interested in this age structural change. In other words, not only are we living longer, but women are having fewer children across the globe. And as a consequence, the average age of the population is going up. The only area where this is beginning, where fertility transition has started but is beginning to stall, is really sub-Saharan Africa. So those low-income countries in sub-Saharan Africa. And so we have this fertility program trying to understand from a population level the drivers of fertility change. And we work mainly looking at the demographic and health surveys, but we also have some anthropological work and indeed some interventionist and evaluation work. So we're coming at this from a health perspective in 2 ways. One, because we know changing health is one of the drivers of women choosing to have fewer children. But also we know, as you know, far better than us, that if you have large numbers of children, then a woman's health is actually endangered. So we have probably the paper I would refer you to is a paper, Channon and Harper, that's just come out in +1, where we look at the changing childbearing or the changing total fertility rate in sub-Saharan African countries. And we also look at the variable desired family size. And we look not only at the traditional drivers of reducing fertility, which are family planning, increased education, and increased health, but we also look at the cultural, social, and economic macro drivers that surround that. But the other interesting thing that may be of interest to this audience is that we, over the last 5 years, have done some very close work with the International Planned Parent Federation. And one of the latest things we've done is my colleague Kenneth Howes and a postdoctoral fellow, Maya Zalinok, have set up a series of evaluations of the way that family planning procedures are themselves evaluated. I'm sure you're all aware that there is some very clear guidelines, but the family planning people themselves will tell you that they don't really have the outcomes that we want. And so we at the moment are trying to devise new guidelines and new measures for really trying to evaluate family planning. And again, if you go on our website, you can see that. The second area is actually something really on older women's health. It's looking at older women's health particularly in sub-Saharan Africa. And this is a study that we're doing with colleagues at Northwestern University in South Africa. And we're using something called the Pure data set. A lot of the work we do uses data sets. And the Pure data set does have data on older adults, and it has a reasonable amount of data on older women. And we have a collaboration with Laura Roll, who is a professor at Northwestern. And one of the first things we did was we did a systematic review of literature on older women's health in Africa, and that's published in the Journal of Public Health last year. And the absolutely striking thing was how little there is out there. If I say, we started with this big sort of data collection, 5,000 publications, wonderful, 25 sufficiently robust for us really to say something. And the two areas where we do have some reasonable robust data on older women's health in sub-Saharan Africa is around falls and around diabetes. And the big call from this review paper, if you want to have a look, is that we need so much more data on older women's health in Africa. I think one of the problems is the kind of thing we heard in some of the first sessions about women, and you put women and old age together, and it really isn't something that a lot of research has occurred. The other really important thing is this definition of old age, because in actual fact, many of these studies took 60 or 65. In the African context, actually, we should be looking at women in their late 50s. So there were groups of women who I think have the multimorbidities we associate with old age that were excluded. But what I'm going to focus on and give you some examples on is this set of studies which we've done. And this is all around the life course and women's health. And we've known for a long time that obviously the life course affects women's health, and it can run straight through into old age. And many of the predictors for a healthy old age or an unhealthy old age, we know now are life course related. But a lot of that data has been around things like health across the life course, income, and education. And what we were particularly interested in, well, what about the life course beyond that? What about the world of work or the world of care or social networks? So, working with Sarah Zeller, who is a postdoctoral research fellow at the Institute, we took SHARE, which is the big over 55 social survey, which is based on the health and retirement surveys coming out of the States. There are now many across the globe. So we have some really good data now on the over 55s. And what we did was we took sequence analysis to reconstruct women's careers in different European countries, and then we looked at what were the measures of well-being, subjective health, and depression in the first 5 years after retirement, or if they didn't retire after 65. I'm going to talk a little bit more in detail in a minute, so I will stop there. We then have taken that and we've done a comparison between French and British women. We just had some funding from the Lundbeck Foundation in Denmark to really focus on Danish women and try and understand not only the life course and all those changes that women have across the life course, but also to understand things like social networks, whether or not they had children and life events, to really understand particularly well-being and depression in later life. We've now just started working on the closer data set, which is the Korean data set, and we're just bidding for some money with some colleagues at PKU in Peking to look at the Charles data set, to see if we can do a European framework project in an Asian context. And this builds on some other work that we have recently done in China with the University of Xi'an, where we have looked at the impact of the one-child policy on care in later life and the impact that has on women's health. So very quickly, just to give you an example of the kind of way that we work, this is that European study on share that I was talking about. Our hypothesis was, just taking work in this particular case, that women with children who could combine childcare and employment would have far better well-being in later life and far less depression. And that was found, in fact, to be the case. But then we thought, right, what we need to do here, we have these different welfare regimes. We have the sort of Nordic regime in the red, and then we have the familiaristic in the blue, that's the Southern European regimes, and then a sort of mixed in the middle. Presumably, given that we're looking at 3 cohorts of women born in the 20s, 30s, and 40s, all entering later life, and that most of these women, particularly in these familiaristic societies, grew up at a time when women of that age were told, yes, you should stay at home and look after your children. They would actually have very good well-being and and lower depression in later life if they had stayed at home and done what their society was telling them to do, which was look after children. And much to our surprise, that was not the case. What we actually found was that regardless of welfare regime, If you are a woman with children and you can combine work and childcare in some way, whether it's part-time or whether it is taking leave, you have far better well-being in later life and actually significantly lower levels of depression. Yeah. And interestingly, this was particularly the case in these familiaristic societies. So in other words, in particular places like Italy and Spain, women had far higher levels of depression if they had stayed at home with their children. So we've now taken this kind of structure, and as I say, we're looking at in different depth within different countries. So that's just to give you an example where social scientists using data. And I want to conclude with this, because this I think is really exciting. So Robin came to me and told me that she was setting up, or with Stephen, this women's health at Oxford, and it coincides with what I think is a really exciting development, which is something that's about to be announced next week. Many of you may or may not be aware of it, called ARCH, Aging Research Collaborative Hub, here at the Oxford Martin School. I think of Torch, and we thought ARCH sort of works. And that is going to bring together, across the university, everybody who works in aging. And to launch it, Robin and I thought it would be really nice to put on this seminar series, which is going to look at older women's health. It's going to be here in the Oxford Martin School. And it combines people who come from Robin's world and from our world. The very first talk is from, if you can come to, is from Carol Jagger, who is a fantastic epidemiologist out of Newcastle, looking at women's healthy life expectancy vis-a-vis men. And then we have Sarah Zeller talking about the study that I talked about. And then we have 3 speakers from Oxford. So please do look at it, because I think it's a wonderful way just to kickstart both our initiatives. Thank you.
To broaden the experience even more, we thought it was very important to have representation from the humanities. And it's a great pleasure to invite Joshua Horden to come and speak to us, who is from the Faculty of Theology and Religion. Joshua.
Well, thank you very much for the invitation, and wonderful to be here today. So, let's see. How do I move on? Yeah, thank you very much. We're okay. We know how to press start. Okay. Thanks for sorting us out there. So yeah, thanks for having us today. And since Sarah's just mentioned Torch, there it is, the Oxford Research Centre in the humanities. And I'll be talking a bit about today about how humanities researchers might be involved in the kind of matters we're talking about. So one way for humanities researchers to engage with health is to look at the stories which surround health. So we might ask questions like this. What have been the stories told about women's and girls' health? What is their history? Where have they come from, those stories? What narratives are important in women's and girls' self-understanding today? How are they told? What meaning do they bear? And what difference do such stories make to health in practice? What just cause do they serve? What injustice do they exacerbate if they do? So why are stories being told at all? Stories often have their own persuasive power. They guide attention, imagination, intelligence, and energy in some direction or another. We know this, of course, from film, from literature, from history, philosophy, and we know it also from health research too. This was mentioned earlier in the day as a quick illustration from the BHF report recently, seeking to bust a so-called medical myth. This is about sex differences in presenting symptoms of acute coronary syndrome. Standard international guidelines indicate that women tend to suffer unusual or atypical heart attack symptoms, but this new study casts all this into doubt, giving evidence that the guidelines are incorrect with significant ramifications for risk stratification and treatment. And the question we might have here is, what are the stories which are operative in research and practice? How do they interface with public understanding, with the common myths, commonly held myths that heart disease and heart attack are really issues for men's health? So hard data is obviously one route to breaking down myth, but our stories, the stories which shape our cultures matter too. What meaning they have, what truth they bear, and whether those stories are mediated in healthcare channels and contexts or more broadly in the wider context. So we're talking about myth, we're talking about story. Narrative is important to research and practice, and it's also important at that broad cultural and historical level. How do we join all this up? Think about the language of the life course, already noted, which is adopted, as you see here, by the RCOG. There's a summary of some of their thinking about it. So narratives interpret the life course. Personal and cultural meanings cross-pollinate pivotal phases and episodes of people's lives. For example, representation of women, girls, and their health has historically been highly significant in how the human life course is interpreted in my own discipline, theology. Think especially of the classic creedal statements, which have shaped theology and religion and do continue to shape people's daily practice around the world. Creedal statements around Christ's conception, birth, life, suffering, death, resurrection, and ascension. What's striking in reading these creedal statements, and indeed the texts which surround them, is how these moments are typically interwoven with women's and girls' health and experience. Have a look at this triptych of images exploring the beginning, the middle, and the fulfillment of the life course, working from left to right. On the first on the left, in the Ashmolean, is the flight of Mary, Joseph, and the infant Jesus into Egypt. You have a young refugee mother following a recent birth, often now associated, this image, this story, with the phenomenon of women at risk through forced migration and war. In the second, the icon there, Russian icon, a woman with severe bleeding, culturally outcast, who was said to have suffered under many doctors for 11 years. She's depicted as reaching out to Christ and experiencing healing. Now, setting aside stigma and shame and ritual uncleanness, they greet and welcome each other. And this is a story which, as this icon shows, has had profound and continuing global devotional resonance over the centuries, also acting as a kind of standing rebuke to Christianity's own failures to engage compassionately and effectively in women's health. And then the last here is in the resurrection appearance, centre stage is taken by Mary Magdalene, traditionally associated with women and girls involved in sex work and so prone to stigmatisation, abuse, and various other health issues. The point is that all these narratives arising in the Middle East and then globally mediated through various art forms and storytelling engage in women's narratives, their experience of the life course, inspiring culture, inspiring also critical engagement. And there are many other examples of the way that humanities disciplines can do this to frame health research. The key point is how life course and narrative intersect in many cultures around the globe. Finally, very briefly, thinking about technology, slide from my colleague Tim Moore, Professor of Clinical Oncology here. We looked at a project identifying various ways in which research and funding culture in cancer is implicated in patterns of promise and hype. Presented this at the British Gynecological Cancer Society in July, looking at these underlying patterns. They very much recognise this picture in their context, that for all the hype and the spend around precision medicine, and notwithstanding some remarkable advances, the yield has not been fulfilled. And so the sheer complexity of the way that precision medicine is rolling out is having ramifications. So the question then is, does the underlying question for research is how to detect narratives and how to critique narratives which distract from a focus on what should be on the agenda, what should be central. How does distraction arise? How can narratives be shifted? The narrative surrounding, say, period poverty and the issues indicated in the George Institute's own research mentioned earlier points perhaps in a complementary or at least different story. So my hope is that our humanities researchers, and here are a few of them, by engaging sensitively and critically with the narratives and underlying culture which around women's and girls' health can play a helpful collaborative role. Sally Frampton there is a historian of medicine who's looked at surgery around ovarian tumours and is now looking at hepatitis B in South Africa. Marie Allett is working on issues of medical professionalism and training of doctors. We want to collaborate, and we do hope that there'll be ways to carry on this important work with you. Thank you for having us.
And lastly, Christian Mondon, who is the head of Department of Sociology, whom I met in this room a few weeks ago, will be giving you just an overview of some of the research that's relevant in his department. Thank you, Christian.
That's more slides than I was expecting. Right, so I would just want to give you an overview of some of the research that we're doing. When I met Stephen here, I thought, well, we don't really do women's health, except for maybe one or two projects. But when I looked around the department, I actually noticed that almost everybody does things that link to women's health, that's important to it. Sociologists study who gets what and who does what with whom, to make it very simple. Who gets the good stuff in life, the good jobs, the powerful positions, income, and how does it change over the life course, and who does what with whom, who marries whom, who lives in the same neighborhoods with whom. So we look at individuals in those kind of contexts, and if health is not the outcome, then a lot of what we study could be seen as drivers of individuals' health and of health differences between different groups in society. I should also say, I haven't included it here on this slide, that the Department of Sociology hosts officially since 2 days ago, the 1st of October, when the first researchers started, the Leverhulme Center for Demographic Research, that has a large overlap with many people in the department, but we will be hiring lots of new people, and we've just hired 6 who are starting. And some people here in the room, Cecilia among others, are members of this new center. And I think lots of work in that center that is about using innovative data, innovative research designs will be relevant for women's health. I thought I have 5 slides. I'm going to try to put to get in 5 examples of studies that are currently going on in the department. I kind of abused my position to start with a study that I've done myself. Twins are a very small group of the population, but in some countries more so than in others. In this area in sub-Saharan Africa, we find the highest naturally occurring twinning rate in the world. You might know in countries like Finland, for instance, with the lowest infant mortality in the world, twins there are still much more likely to die than singletons. Even though their mothers have been in the medical system from the beginning, often because the reason they have twins is because their pregnancy started in a medical setting due to IVF, for instance. Now, what happens in a setting where there's high twinning and healthcare facilities just aren't as good as in other parts of the world? You have a very high death rate. So we calculated that 300,000 twins each year die in Africa, and that's over 10% of the overall under 5 mortality. A woman with a twin pregnancy has a more than 40% chance that at least one of her children will die before that child reaches the age of 5. We published this a couple of years ago, but we haven't really been able to do anything with it. Probably because I and my co-authors should have been talking to some of you in this room before then, so I'm really glad that we have this opportunity here today. Because this probably isn't, well, it's not good for the children, but it's also not good for these women at all, and it's a huge number. At least I find it's quite upsetting high numbers. But twins tend to get left out of the big consortia and data collections for all kinds of reasons, but although they're a small group, I think this is a really large number. So this is kind of more straightforward demographic work that goes on in our department. Something also in sub-Saharan Africa that is more about social interactions is a work by Heather Hamill, who comes at this from her interest in trust and in situations with a lot of uncertainty. How do people interact with each other? How does that affect their outcomes? And she's now studying that with regards to medicine. Counterfeit medicine, substandard medicine are a real problem all across the world, but in sub-Saharan Africa in particular. So in a situation where there's high uncertainty about the things you buy, how do people go about buying medicine? Who to trust? And she's done field work with anthropologists and medical doctors on a Wellcome Trust project. with a view to understanding these interactions and understanding how regulation of these markets can better help people. The link, I think, to women's health is that women buy more medicine than men, and they buy particularly medicine for their children much more because they are primarily engaged in the healthcare for their children. And when I spoke to Heather about this, she said, I actually like to develop this gender dimension here much more. For sociologists, thinking about, the standard dimensions are gender, age, socioeconomic position. But in this project, that featured less, but she would be really interested in developing that more. Still in Sub-Saharan Africa, working with data, combining different data sources, linking GPS data of the demographic and health surveys to data on climate, on crops, on roads, etc., is something that Liliana Andriano is doing. She's joining the Levium Center to look, for instance, at these maps of women's decision-making in health care, so to the extent to which they report that they themselves make decisions about health. Using this more granular data allows us to better understand differences within countries, but also diffusion processes and linking that to all other sorts of development in Sub-Saharan Africa. And then lastly, I'd like to talk about Ridi Kashyap's work and the work by Melinda Mills. Ridi Kashyap, a demographer, initially studied sex-selective abortion, but then from sun preferences in the Indian subcontinent, but then also looks at how that later in life affects health and well-being of girls and women, and more broadly is interested in sex differences in all kinds of demographic mortality outcomes. Melinda Mills, who's the director of the Levium Center, has tried to bring in genetics into social science research, the kind of studies we've seen before, but for sociologists that sometimes is something very new. She tries to bring that in with regards to fertility and age at first birth. So again, questions with direct relevance for women's health. And in a very different but important way, has looked with Charles Rahal at something that's been mentioned before, these genetic data, where in the data themselves, women are underrepresented. But they also published a study that showed that actually women are underrepresented and other groups as scientists on these projects on all kinds of boards, and I don't need to tell you that we need to make sure that in all the dimensions of our research we increase diversity and make sure everybody's represented to increase the quality and usefulness of our research. I'll leave it at that, and I hope to see many of you in our new building of the Sociology Department at the Levium Center sometime soon. Thank you.
Our last speaker was due to be John Geddes, the head of the Department of Psychiatry. Unfortunately, John is not well. However, he considers this issue so important that he's actually emailed me a message to you. It's a bit like the Oscars. We don't have a video from his sickbed, but John says the following, 4 points. First, women's mental health is a global priority, and he would be very keen to work with people in this room on setting priorities for women's health at Oxford. And secondly, he draws attention to 3 prominent groups in his department. The first is led by Alan Stein, who works on the relationship between maternal mental health and early child development across the globe, particularly in low to middle-income countries. It's Alan's pioneering work that has described the very strong effect that maternal stress during pregnancy has upon cognitive and emotional development right into childhood. He says that Kate Saunders and Anne Duffy have just launched You Flourish, a survey of student mental health which is very relevant in view of the high levels of depression and anxiety, particularly amongst female students. And lastly, he draws attention to the work of Stephen Friend and colleagues, who are developing pioneering methods of empowering people to protect and improve their mental and physical health using digital technology. particularly applies to the use of censors in pregnant women, and also midwives looking after pregnant women. I know how strongly John feels that this initiative should include mental health, and he apologizes again for not being here. Could I just then invite everyone who's just spoken up to the platform to take some questions. How are we doing for time? I think we're doing quite well. Oh, fantastic. Oh, gosh. It only goes to show how well people have performed.
So here, my question is for Sarah. Hi. Since I come from Spain, and you were mentioning Spain and Italy, former in the times as family surroundings, as family countries, I wanted to just emphasize that since 1975, and 30 years later, Spain is the country in the world that has the quickest sociological changes of any country in the world except for countries under war, because women started to work directly, massively, from being at home, as you were mentioning, started to work massively, and started to go to university also massively, and after Franco died. So it's very interesting that in the mental perception of all of us, not mental, just in the psychological perception, we think of Spain as being a family country, still now, and I just wanted to make sure that at the moment is absolutely the opposite. So we have a ratio of employed women that is higher than in Germany and in many countries in Europe. I don't know whether that has increased our mental health, because it doesn't look that great, but that's just subjective.
You know, I mean, I think that's. Does that not work?
I think that one's working.
Okay, so I think that's a very interesting point, and there are a couple of things. I started as an anthropologist, and if you'll notice that nearly every time we've talked about doing one of these studies, we look at the demographic and health surveys, or we look at the big data surveys, but then actually we try and get collaborations in the country, which is why we've been collaborating with Paris Descartes on the Paris, why we're collaborating with the University of Copenhagen on the Danish work. So I'm fully aware that we have to take into account, when you're trying to interpret cross-cultural surveys, you really must, I think, understand the dynamics. And I think that the two things to point out are, one, of course, we're looking at women who were born in the 1920s, 30s, and 40s, because they're now older women. But also, what we did was that there are certain sort of welfare regimes that are generally recognized, although partially contested. And a lot of it is about the support given to women. And Spain and Italy are both in a category where there is far less public support for women to work, i.e., to provide childcare, etc., as well as social norms in the workplace. And that's why we use that recognized categorization. But I think it's an important point to understand about context. Yes, thank you.
Oh, looks like Susie's there.
Thank you. My question is to Katerina. I found your presentation incredibly powerful and highlighted a huge number of serious big issues. And my question to you was, I don't know how you identified ways about potentially changing these scenarios, changing these situations to help these women out, because they just seem so big, so broad, so ingrained. And I wondered if you wouldn't mind commenting on that.
That is a big question too. I think what we find in water is it still seems to be quite far behind in consideration of gender. There's been a lot of rhetoric around women and water, but there still isn't the sex disaggregated data for a lot of the work, or where women are included, they're very much seen and discussed as victims. So it's the burden of water carriage on women, it's the burden on women. and used for those purposes for generating funding and all the rest of it, which is very important, but doesn't necessarily benefit them in the long run. And I think there's a lot of work that's being done in industry to get more women involved in decision-making levels that might hope to change some of that over time. At the local, I think there's different layers. There's that the research needs to identify gender more adequate, more clearly. And that's not just women in all settings. Certainly we find household surveys will just be done with women, and we won't get men's opinions because they're not in the house when we want to collect data. So you get different inequalities in that way, but we need, certainly consideration at the local level, and in evaluations that, again, intra-household differences are considered. But then there is that more industry-wide one, and that was raised earlier as well, that we need women throughout the industry to help push some of these agendas and make some of these differences clear.
Have you got the mic?
So perhaps a panel for, a question for all the panelists. Many of you sort of mentioned peripherally violence against women as something that impacts on all of this, but that's not been lifted out as a separate thread here. Do you see that as something that's just integral to all of these questions, or should it be a separate thread that should be investigated?
Who wants to start at that end?
I'll say both, not because that's the easiest answer, but it is investigated as a separate issue. For instance, the study I showed on women's empowerment, the same kind of data there is used for intra-household violence, which not exclusively, but the majority is male to female rather than the other way around. But I think that's studied as a separate issue, but I think it needs to broaden out because it's a part of more general power dynamics that hamper progress in all other fields, I think. But I mean that's a very generic answer. It's difficult, I think, to broaden it out through all kinds of different topics. But in a way, I think that kind of mainstreaming is important.
How much to add to that? I think you have to look at the impact of violence against women on all sorts of other effects in health. And you have to look at the source of violence against women, and certainly if you're looking at theology and religion, or looking at culture and practice, you've got to think about what are the ways that women are being protected in any given culture, or are not being protected, or are being endangered because of, say, religious practices or theological beliefs. You've got to look critically at that, but it'd be difficult to single that out as being sort of an entirely separate thread from many of the other things we've spoken about. I think what's the big narrative? What are the big narratives behind the way that which generate violence against women would be a way of connecting with the kind of history or literature or culture of a society, but I wouldn't separate it out.
I think both my colleagues have sort of answered well, and I just want to highlight that in our women and older women's health seminar, in fact, our last talk here in 8th week is called Exploring the Impact of Domestic Violence and Abuse on Health and Wellbeing of Older Women. So clearly we believed it was important to put into a health seminar.
And maybe just to respond also, Melinda Mills from the Leverhulme Centre wasn't able to come here, and neither were Sandy Fredman from the Human Rights Hub, wasn't able to come, and also Maureen Kelly. Is Jen Roost here? No, Jen's not here at the moment, but Maureen Kelly from Ethox, and they've been doing some work on gender-based violence. But I think one of the things that will come up more is we do want to find out what other people are doing, because we're sure there must be people doing work on gender-based violence. I know Nandini Guptu in Department for International Development, who's just got been funded to do some work on gendered violence in India.
And we have a colleague, Brenda Kelly, who works on female genital mutilation, who unfortunately is out of the country, but was definitely... She's following you on Twitter.
Yes.
Could I ask you a question? But I want you to take your specific research hat off and answer from the perspective of your discipline. So, which do you think should be the research priorities if we are genuinely going to embrace transdisciplinarity? Where do you think what should we be focusing on? What should the research, I'll give you a bit more, what should the research priorities be? Another way of looking at it is, what are the major barriers across the world to improving the health of women and girls? Sarah?
Well, I mean, definitely from our perspective, it's inequality, without any doubt at all. And I think if you can tackle inequality, then you can... I mean, when we look at things like life expectancy and changing life expectancy, we now know that one of the reasons why life expectancies are stalling in high-income countries is because of inequalities in the population. So the higher socioeconomic groups in the most affluent areas, they still have increased both life expectancy and healthy life expectancy, but the gap is widening. And for women, life expectancy in this country is actually now falling in those lower socioeconomic groups. So inequality would be what we would say was very important.
I would add to that to say getting the data to highlight those inequalities as well. Some of the work that's already been done in the report and looking at the sex differences, there's still a lot of data missing on those points, where we can make a lot of progress just by highlighting these gaps. And so I think that's one real area in terms of the data and to highlight these inequalities that can be done.
In order to make effective arguments against inequality, you've got to have good, strong arguments for justice. And that's where it seems to me the role of ethics and philosophy and theology can play a role, and history and literature, highlighting where there have been historic injustices, and then marshalling energy and people's common purpose in order to tackle deep questions of inequality. I'd also say, just from listening to the fantastic presentations which we've heard today, how the kind of basic science which is being done here and in other contexts is received and bedded down in quite different cultural settings, in which the narrative of human life as to what's important in life, where life is going, why health is important, what's valuable to people, may be quite at variance from what are sort of the given assumptions perhaps here. So I think really understanding, with the benefits of our sociological and ethnographic colleagues, what's going on in contexts where you're looking to, as we land a very important piece of research, trying to draw the narratives of people into the research itself in terms of their culture, worldview, religion, belief. I think that's an area where we could focus together more, find out, is that actually a problem? Is that a problem for landing research effectively and improving health? If it isn't a problem, bracket it out. But if it is a problem, how do we actually draw together the resources of the university? We're attempting to do, as I mentioned earlier, in a project we're hoping to get funded in South Africa, looking at hepatitis B and MMR take-up, vaccine take-up in KwaZulu-Natal. So that's a context in which we're looking at religious belief as to what kind of factor it is in vaccine hesitancy. So that'll be a test of that. We'll see.
I've got very little to add to that because I fully agree, but I think we still need institutional change to get to a situation where, for instance, it's simply unacceptable that we wouldn't have data with enough diversity in the kind of straightforward demographic studies that we do. There's usually data on men and women. But as soon as you want to bring in more information, that becomes a problem. And we've just recently, for instance, been looking at collecting across the world as many surveys as we could to compile on family formations and the importance for family of labour market careers. And the number of countries where if you go a few decades back, you will find questionnaires that were either only asked to men, about men, asked questions about their brothers or only their fathers is quite remarkable. And in some cases it goes up to 1995, where the surveys only included men and not women, because apparently they weren't interesting. And that simply has to change and has to be something that outrages everyone. And because otherwise we do need the data. We won't be able to make the progress.
Hi. Oh, sorry, it's a bit loud. As a follow-on question, really. Thinking about health in its most holistic definition, it's not just biomedical, it's not just the absence of disease. WHO says it's about, for women's health and reproductive health, definitely it's about safe and pleasurable sexuality, and it's not just about STIs and things. And as clinicians, sometimes we get so caught up in the biomedical silo of they have this disease and this is a treatment, the diagnosis. And our research then naturally follows that with numbers, which I love. But I just wondered what your thoughts would be a more qualitative research. I know the DHS is probably still more quant, but how to bring in that qualitative, experiential things to both research, but also our interaction with the women that we see, because that is also key. And I think I know that I don't do so much of that.
Lisa's gone.
A clinician said to me, I'm not a clinician, you're a clinician yourself, yeah. The question he always asks when someone comes in the room is, what's important to you in this consultation? What's important to you in the way this treatment works out? And that will, of course, include, as you said, a range of experience, including sexually pleasurable experiences for women. So there's a whole skill, isn't there, of counselling and consultation, which focuses on what's important to patients. One of the things I was talking about in the coffee break with a colleague is, well, that works well on an individual basis, but how about on a community basis, where you're looking for an application of the science for a whole community? How do you continue to keep that kind of focus on what's important to individuals when you're looking for a community application? That seems to be a challenge, a cultural challenge. And when you encounter cultures which are quite different from one's own, what's important, again, doesn't look like one's own. How do you navigate that? And that, to me, is a sort of core ethical question of the way that the kind of basic science works out. That'll be the start of a response, but you do got to have a qualitative work which backs it up. Otherwise, you're kind of you're liable to miss what's important.
Last question from Chaz.
Thank you, Stephen. Maybe a slightly provocative question, but I mean, I hadn't appreciated across this great university there was so much activity in this space. And I'm just wondering, collectively, what impact have we had? I don't know, in terms of policy change or something like this. And maybe the other way to answer that question is that, Stephen and Robin obviously have a dream vision here, and let's assume that becomes a reality. Collectively, what do we want to achieve, let's say, in the next 5 years or 10 years? And I suppose it's going back to your question. I mean, I'm just thinking of sort of what impact do we want to have? What output will we have if we create? I don't know if that made sense.
That's a dialogue, and it's becoming increasingly important. And I absolutely agree with you. In fact, when I'm going to address this issue when I introduce the VC, because I think it gets at the heart of what should a university be in the 21st century, actually. Before I thank the four speakers, Robin and I thought it would be nice to sort of a dating game. We're very conscious of the fact that we've chosen a limited number of examples of what's going on. Would anyone like to stand up and in 1 or 2 minutes just tell us what contribution they're making to women's health? Anyone wants to be bold? Ahmed. Fadil. 1 or 2 minutes.
Well, I only work on ovarian cancer, so I suppose I'm limited. And again, I'm very, very strong gender inequality, very biased in what I've chosen to work on. Yes, so my work is on understanding tumor initiation and progression of ovarian cancer as a disease, and how at the molecular level and how this understanding can help with issues like early detection and also designing better therapies for patients. And I was very intrigued by the slide that showed that how many of the treatments only improve progression-free survival or overall survival by 2.5 months. Great slide. But then the impact of some of those therapies on the individual, not the disease, can be tremendous and highly significant. So that's something that's definitely worth focusing on.
Hi, I'm Fadil Hannan and I work in Stephen's department in NDWRH. And so I'm a physician, but I'm very much interested in understanding the basis of biology, really. And one of the things that I'm looking at, which is very well characterized actually in the cattle industry, but not so much in people, is how mums produce milk. And so I'm interested in looking at the biology of lactation and understanding how a mum with sort of well-established lactation can produce up to 1 litre of milk per day. It's quite incredible, how do we turn our blood into milk? And that's sort of a process that sort of fascinates me. But another aspect is how sort of lactation can have quite interesting benefits on mum's health. For example, it's well known that breastfeeding protects against breast cancer, and it's always sort of intrigued me. Is that because mum, while she's breastfeeding, just takes better care of herself, will smoke less, will drink less, will eat better? Or actually, is there sort of hard biology that breastfeeding sort of confers some sort of biological benefit that 20 years down the line can reduce the risks of getting breast cancer? So that's just an insight in sort of the work that I do.
And in fact, it occurs to me that the opportunity for collaboration with both the humanities and the social sciences is enormous. Enormous.
Absolutely.
Hi, my name is Ingrid Granner. My research interest is mainly around miscarriage in quite a number of areas, I guess, but fundamentally it's about the immunology of miscarriage and how the pregnancy is tolerized by a mother. Also branching out, I guess, more and more, have collaborations now with people in anthropology here, so looking at the maternal investment in pregnancy, looking at what the importance of fetal remains are to women, and also much more clinically, I guess, looking at where women and how women have miscarriage and want to be cared for, and how that experience is for them.
Hello, my name is Dana Ongari. I'm an MBA student, and I come from Nairobi, Kenya. I'm trained as a medical doctor, then did public health in Belgium, UK, then I went back home in Kenya. And what we do is we set up rapid outpatient clinics, and we have a list of services, but part of it is maternal child health. Now, what we specifically focus on is more on what people would say the softer side. And this is more on mental health and counseling services. And what we have found, as much as we see patients with, diagnostic conditions, they often have sort of a list of mental health support services that they don't receive from hospitals typically, right? And they'd come to us, whether it's endometriosis, whether it's even diabetes, they've given birth, it's miscarriage, right? And we found that we neglect this as healthcare professionals. Oh, sorry, too much.
I'm in trouble. I'm in deep trouble, Robin.
Exactly right. We often neglect this as healthcare professionals and even researchers about just the qualitative side of it, because as a human being, as someone mentioned, we're holistic human beings, and we have found whether we work in Kenya, Uganda, Rwanda, and recently South Sudan, and regardless of what country it is, no matter whether it's an urban or rural setting, there are women who come out and say, you know what, I just want to talk. Because, for example, my husband doesn't appreciate that I use a contraceptive device, And I thought I'd just mention, as you're continuing with your different projects, never forget about just what we'd call the softer side as well.
who want to date will have an opportunity to do that in the next half an hour. And so I'd like to thank our panel, the speakers that we've just had. And as Stephen has said, really, we're just highlighting some of the opportunities, some of the research and some of the opportunities that there are to engage in women's health. What we want to do in the next half an hour before the Vice-Chancellor joins us is to talk somewhat briefly about what we think. Is this better? Ah, 'tis too. Right. So what we would like to do, we think that there is a real opportunity here with the sorts of things that we're learning about today. We know there's more happening across the university, but we think we could do a lot at Oxford if we work together to address women's health globally. We believe that we could do a lot to reduce inequalities in healthcare. So what is it that we want to do, and how can we go about doing that? Now, Stephen and I, with others, have worked on a vision of what we think we could do at Oxford that we want to present to you very briefly, and then talk about some opportunities for how we might start to do that. But then I want to come back to the group here and get a few more ideas out of the group. And then towards the end of this half hour specifically, I'm going to get you to get Mentimeter out, your phones and your computers out, and we're going to ask you a few specific questions that we hope we'll be able to present the answers or the responses to after the Vice-Chancellor's panel and before we go to drinks. So let me just see, will my slides come up? Oh, right. Oh, while Elisa's getting the slides set, just to reinforce our commitment to women and mental health, as you came just outside the door, we left a number of flyers for those who are particularly interested in this area to pick up. The George Institute's Women's Health Program have been fortunate to lead a WHO community of practice on women and NCDs, and our next webinar, which is on
the 15th of October.
15th of October, Elise is very much involved in this, is a focus on women and depression.
Correct.
So anyone who is interested in joining that global community of practice, please do pick up a flyer. So, right, okay. So, what do we want to do? Well, on your seats, you will see a brochure that we have put together, which is about the vision that we have for women's health at Oxford. We think, and as you can see, our vision is very much supported by the Vice-Chancellor, which is why we're thrilled to have her presenting in the next session. But we have outlined a vision that talks about taking a life course approach, a transdisciplinary approach, and we believe at Oxford we can do something unique globally. Oxford has such a fantastic brand globally that we could be a hub nationally, we could be a hub internationally. We have the ability in Oxford to work with partners across the UK and across the world to ensure that the social, political, economic, environmental and cultural factors that impact on women's health and lives are considered. We want to continue to excel in undertaking research on sexual and reproductive health, the traditional domain of the Nuffield Department of Women's and Reproductive Health, but integrate this more strongly with a life course approach and investigate how the latter impacts on future health, especially cardiovascular diseases and diabetes, and the other leading causes of death and disability. We want to ensure that we have a focus not just on girls and younger women, but also, as you've heard, on older women. We want to ensure that we integrate research on women's physical health with women's mental health. We want to continue to support research on sex differences and research that takes a gender perspective. We'd like to reach out and engage consumers in our work, whether it's in Oxford, rest of the UK or globally, and to work with policymakers and practitioners to ensure our research is implemented and impactful. We want to be leaders in undertaking an intersectional approach to our research, as some people have started to identify in the previous session, to ensure that no one is left behind because of their ethnicity, their gender identity, or disability, for example. So how might we start to do this? Well, some of you may be involved in AFOX. Some of you know that I think they're doing a fantastic job. We invited Anne McKenna and Kevin Marsh to join us today to talk about the model of how AFOX is becoming a strong force in the University of Oxford, but both are away in Africa at the moment. Nevertheless, we have been very impressed how over a very short period of time, the AFOX team, the Africa Oxford Initiative, have grown to bring together people involved in research in Oxford who are working with colleagues in Africa. AFOX have developed a website portal and an infrastructure which provides a database of researchers working with African colleagues, updates on funding and other opportunities, as well as events. So we think we should do something like this. It was a challenge for us to go out and find who's working in women's health space. We've managed to find over 100 people who are interested in this space, but we're sure there are many others. So maybe a first step is to do something very similar to that which AFOX have done. Develop a shop front that would help us to identify who are the researchers, what are the events going on, what's happening, what are our successes in the field, and what are the funding opportunities to take us forward. But what we want to do now is to hear your thoughts on that. Do you think the idea, the vision that we've outlined in the brochure that you've had, is that a vision that excites you? Do you want to be part of what we're talking about here? And how do you think we might do that? So we're going to we have about 10 minutes to get some ideas going, and then we're going to put up Mentimeter and ask you some specific questions so that we can use those questions to really take this initiative forward. So if I could ask people to jump up quickly and say, yeah, I want to be involved, or I think this is a good idea, or if not, tell us a different approach that we might consider. Think about how we might get working together on this initiative. So please be brief so we can get as many people providing their thoughts as we can. Anyone interested? Nodding, but perhaps a yell. Okay, yes.
Hi there, my name's Deborah Spencer and I'm the Deputy Head of one of the Industrial Research Partnership teams at one of the BD teams across the university. And I have to thank Alyssa, Stephen and Robin for inviting me to learn more about this because, well, I actually look after the industrial strategy for the university as well, which is funding that comes from the UK government. So learning about this and coming here to this seminar has been really informative and getting the research that's going on onto our radar so we can take it back to our BD teams. One of the things that we do is we have relationships with industrial partners. So getting them to understand some of the research that we're doing is really important as well. And I think you're doing an amazing job. And just yesterday I was at an Industrial Strategy Challenge Fund event on healthy aging. And interestingly enough, we talked about the gender issue. So I think there is a lot of dialogue out there already about what's going on. So delighted that you're doing this.
Thank you. Other comments? Yes, thank you.
So I'm a health economist, so I sort of exist at the intersection between basic science and social science. And I think what's potentially really exciting about this initiative, and we've seen it with the 2 different sessions, is the potential to bring the social science and the basic science much closer together. I feel like what I've seen so far has been a lot of separation between the two, and I think we gain a lot by bringing those closer together, and perhaps this is a forum by which we can do that more.
Thank you. Jill. Stella. Oh, we got somebody here. Oh.
Did you want to make a comment or? So you were saying, is anyone interested? Yes, I'm pretty sure we're interested. So I'm from the Department of Primary Care, and we already work with the health experiences group. So Lisa spoke earlier, and health economists, and some people in psychology. But yeah, we're in. We look a lot at self-management and self-monitoring, so taking women through their pregnancies and things like that.
Sonny and Stella.
Yes, thank you. I will be very brief. So in addition to what was just said, interdisciplinary is really important. I'm coming from Canada. Thanks to Robin who invited me here. I think one thing that we need to keep in mind, if you want this to be a hub, you just said that no, we want Oxford to be a hub. So in addition to interdisciplinary, I think that no, international collaboration also is really key, because there is a lot going on elsewhere when it comes to women's health, and I think that no, we really need to try our best to bring the best of the best here as well. Thank you.
Stella.
That's not what.
Yes.
Interdisciplinarity is a very nice word, but it's very difficult to make it work, because I would suggest that if what we want to do is to exchange, then it's something different than if what we want to do is to publish. I say this because if we are too quickly going into what the profession needs from us, which is publishing, etc., then we won't be having time to talk to each other and infuse each other's research. So I would suggest time to talk, absolutely, just to seminars or talks or lectures where we listen to the others a little bit before trying to do something together. Otherwise, we don't share the languages.
Two more. These two?
Oh, you got it.
I also wanted to talk on behalf of the humanities. As we have heard from humanities speakers today, the humanities priorities are as follows: looking at myths, narratives, concepts with a dual perspective, critique of myths, narratives, concepts, and then a revision that we might find in philosophy, in women's writing, and so on and so forth. It is difficult to find ways to bridge a gap between this kind of project and big data, and I'm listening with great interest, but it's something that can't happen immediately.
Hi, I'm Karine Asnong, and I worked with adolescents for a large part of my life in preventive healthcare for adolescents in Belgium. But since I'm here in Oxford, I'm actually very interested in giving the adolescents themselves a voice, because we talk about women, but the girls are actually the women of tomorrow, the older women of tomorrow, and a lot of the gender roles and a lot of the habits, lifestyle, it's all happening and installed early in life. And I'm just wondering if we can, because adolescents are not children, they're not adults, is there a way of bringing their voice into the conversation? Because I think in this country, quite a lot of them are, but especially low and middle income countries, vulnerable adolescents, orphans, kids who are not going to school, it's already hard to include them in research because of ethics, because of a lot of things, consent, assent, rules that are different in different countries. And the more vulnerable they are, the harder it is to bring them into the conversation. Is there a way of bringing them in? Because if you want to do things for them, I think you have to do it with them. They need to be the co-creators. And I would really, really encourage everybody here to think about that. How do you bring the adolescents in, the young girls?
And I think just to add to that, I guess I used the comment about engaging with consumers as the language that's used. And I think that is, as well as interdisciplinarity or transdisciplinarity, it is being required by funders increasingly. There does need to be a patient voice or a consumer voice, and whether that's adolescents or whether it's older women. I think that's why we need to move from talking to ourselves in this environment to reaching out to those groups. So one more person who might want to say something, Josh, before I get you to arm yourselves with your phones. Josh.
Just to emphasise what's perhaps obvious, which is the opportunity for education within this city, both with Oxford Brookes and with this university, as to how we can collaborate, focusing on medical students, nursing, midwife students, and the opportunities to think about what is it to be a professional health person these days in terms of the kind of sex differences, gender questions which we've thought about, so that the researchers and the healthcare staff of the future are fully engaged with the kind of questions we're looking at today. And that's a great opportunity for our work together in the future across disciplines.
And that, just to perhaps add to that, it's something that Stephen and I have been talking about with others, about whether there would be a time when we look at offering a master's in women's health, because there doesn't exist something like that at the moment in this university, or indeed when you're thinking about women's health across the life course, and as far as we know, in any other university in the UK. So something for us to consider as well. But let me move to this last session. We have 10 minutes. I'm going to ask questions. I want you to get your phones out. And as we said, menti.com, and use the code 418252. I know some of you may not have phones. Write down your comments and just pass them to us on a piece of paper in that case. But I would like you to say, given today's discussion, in 2 to 3 words, please describe women's health research themes that you might like to pursue within a multidisciplinary team. And I see you all looking back up at me here. I'll then move on to the next question. It's a wonderful silence, isn't it? Okay, next question. What would a women's health at Oxford portal include? We gave the example of the AFOX website portal and the sorts of things that they have on it. They've talked about searchable database of Oxford women's health researchers, opportunities, vacancies, fellowships, research funding, communication of Oxford research achievement, or maybe you don't think we need a portal. But please fill in as many of those, or tick as many of those as you think we might usefully use. It should be a pretty easy exercise, the ticking. What kind of women's health at Oxford events would you be interested in attending? Transdisciplinary seminar series, which hopefully the Women's Health and Ageing seminar series that we've got coming up is starting to do a little bit of that. Networking events, which are socialising. Knowledge exchange opportunities between researchers and policymakers, implementers and or patients, or anything else. Do you want to be involved moving forward? Please tick yes. I'm not biasing the responses here. And if yes, please tell us your name so we know who's interested in engaging with you. We've got all your names, but we're not going to assume that you all want to necessarily engage, but please tell us your name. And then we know we haven't captured everyone in the university who might be interested in being involved in this. So if there's any of your other colleagues who might like for us to reach out to. We did have a debate about this and whether this fits within the new privacy regulations, but I think we felt this is about sharing to say, hey, contact that person to see if they'd like to be involved in this. So we think that should be adequate. Well, that's another way if you've got concerned about it. It's one of those things we talk to each other, hey, who do you know might be interested? What do you think? Oh, I'll contact them. So if you would like to engage further, how would you like to contribute? Please let us know. That's it. The questionnaire is done. Has it been done? Yeah. So, have I? No, I don't seem to have another slide here. Lisa thinks it could be another one, but I can't find it on here, so...
Oh, no, I just meant that we were delayed with the Mentimeter.
Oh.
Yeah, no other slide. It's
No.
just that it was a slide behind.
Oh, okay. But we're all okay. Good. Okay, so we have about 5 minutes. We're waiting for... We have all our panellists here for the last session. The Vice-Chancellor said she'd be arriving at 5 o'clock. So people can either take a short break or if they want to raise any issues with us at the moment. Otherwise, we'll... yes. Do you have any? So Lisa was just reminding me that we did have a few people ask some questions. Oh, no. We won't. It looks like we're going to be moving into our panel now, and Stephen I'm going to pass to Stephen to introduce the Vice Chancellor.
Could I invite the panelists to the last session? Alison, Sue, Chaz, Jan. Before I ask the Vice-Chancellor to chair this last session, could I just point out to everyone that over the last few months, Robin and I have been knocking on the doors of some very senior people in this university, asking them whether they thought this whole initiative was a good idea or not. And I'm delighted to say that everyone we've been to speak to who's important has welcomed us with open arms, has said to us that this is an extremely exciting thing to be doing. And no one has been more supportive than our Vice-Chancellor. And we're extremely grateful to you, Louise, for coming to chair this session. And if you'd be kind enough just to introduce people on the panel and leave it to you.
Thank you, Stephen. Good afternoon, everyone. So we have an all-star lineup here to help us address the question of how can we enhance transdisciplinary collaboration across the university to improve the health of women and girls around the world. And in 45 minutes, you will know the answer to that question. Thanks to our extraordinary panelists. On my far right is Chaz Buntra, who is the Pro Vice Chancellor for Innovation, and he is also co-director of the Oxford Martin Programme on Affordable Medicine. He is Professor of Translational Medicine in the Duffy Department of Clinical Medicine, spent 19 years in the pharmaceutical industry, and has been an indefatigable, incisive, and unfailingly positive, and you've no idea how important that is, colleague in the senior team at the university. So it's been an absolute pleasure working with him. Alison Noble is Technicos Professor of Biomedical Engineering. She's a Fellow of St. Hilda's, Associate Head of MPLS. She works in a range of fields: medical imaging, obstetrics, prenatal development, ultrasounds, and many more. And an extraordinary intellect and talented engineer. Sue Dobson is the Rhodes Trust Professor of Organizational Behavior at Saïd Business School. She's a Fellow at Green Templeton College, Deputy Dean of the Saïd, has led a number of projects in the health services area, so brings a different perspective. And finally, we have Jan Royal, Baroness Royal of Blaisdon, who is the Principal of Somerville. She served as Leader of the House of Lords and Lord President of the Council, and you have to rely on her to explain what that means. But I do know that in the Lords, she was the government, that is the Labour government, spokesman for health, international development and foreign affairs, and again has been a wonderfully innovative, inclusive and energetic leader of Somerville. So, we have quite a practical but big question to address. So let me start over there with you, Chaz. What innovative approaches might we need to grow women's health at Oxford, do you think?
Well, I think one thing, Louise, that's worked well in Oxford is that when we've identified a problem and we've created some sort of home or centre or institute, that's been a convening place. And so I think the Big Data Institute's been a phenomenal success. I think the Institute for Biomedical Engineering has been a phenomenal success. Louise, you're pushing the AI and ethics. I mean, I think that, no doubt, that will be a great success. So I think that's something we should think about. This is obviously a massive problem, a big global problem, and we need to come together, so maybe create some sort of home or centre or institute. Secondly, I think sort of it's so important to identify the right leader. So maybe, I don't know, whether we have a chair in women's health. I think something like that is worth considering. I would also think sort of, let's do something completely different. I mean, sort of, don't automatically base the center in medical sciences. I mean, clearly there's lots of interest, expertise in humanities, social sciences, MPLS, etc. Maybe base that center in one of those other divisions. And again, don't necessarily just appoint a leader who's a woman. Obviously we'll appoint the best person, but you know, sometimes actually a man leading something like this might be quite interesting. I think I would also...
You may be in a minority.
I would also think maybe, I don't know, maybe I think linking it up with a college, I think that could be very powerful. But I think whatever we decide to do, let's be really ambitious. And this was my earlier comment, Steve and Robin. I mean, sort of, let's think of some goals, some outputs. We're not just doing this because we want to come together and talk to each other and have sort of nice discussions. Let's think of what we want to achieve in 5 years, 10 years, etc. You know, we're going to create a pipeline of new therapeutics for diseases associated with women's health, etc., etc. We're going to, I don't know, produce 3 policy papers in the next 5 years, or we're going to build 3 big partnerships with industry or with patient groups, or something like this. Let's have some big goals.
Alison, what do you think engineering sciences can bring to this?
So I think, sort of building on what Stuart said, I think the previous success stories, including the Institute of Biomedical Engineering, has been very much where you brought people together who haven't also worked together before. And I think the listening to people today, I personally as an engineer, I start out by listening. I do not know exactly what the engineering solutions will be. There are some obvious ones to think about, how you might use things like smart sensors. We know how to model problems. But I think particularly I've been working with Stephen, it started out with conversations and not really finding the right questions to work on together. But over a period of time, you get more ambitious in the question you want to ask. And I think everyone needs to be more ambitious than maybe you're thinking now. Forget about the barriers, and particularly the barriers of technology. Often people try, if they work with engineers and people in physical scientists, they will talk about a problem they think technology today can solve for them, rather than come with the question they want to have solved, and that becomes a conversation. So in working with Stephen, I've always started with what is the big unmet clinical need. I don't want to know about the technology, I can think about that. So I think the interdisciplinarity goes beyond just health and clinical and engineering. It goes out to think about end users as well. So that's when you bring in social scientists as well. And what excites me as an engineer at the moment is how we bring everything together. I think working in a university like ours is a very special place to have these experts, but we don't have the connections yet, I think, and it'll be exciting going forward to be able to work on that.
Okay, thank you. So Sue, from the organizational behavior background, what do we have to do to, as a complex organization, to encourage an entrepreneurial approach to this?
Okay, so I think this is a wonderful opportunity for us to have new conversations. And when I think about women's health, I mean, from a business school, we talk about change challenges, and this is certainly a wicked problem. By which I mean, you know, the solution of making progress involves us all talking to one another and not being tribal in the conversations that we currently are having. So in that sense, we know that the leadership of that kind of initiative, building a context where people can have conversations they wouldn't normally have. And actually, crucially, I think aligning incentives. A lot of the work that I've done in healthcare, trying to get people to work together in teams and across boundaries, is often being the incentives that haven't really been aligned, and we need to think a bit about that, as well as the language. And so we need to find a common language. I think your point about having more conversations becomes very important in that. I mean, in the business school, we talk about being a business school in a university and kind of collaborative opportunities that we have as a business school, and some of the work that we have done tries to do that. So we've been deliberately partnering with the Smith School to think about women's health in terms of the issues around water and how access to clean water can help women's health and education. So there's lots of examples, I think, of partnerships that actually happen, and maybe we should really begin to explore what's worked and why, and building on what we know. And I think the notion of mapping who's doing what and then thinking about connections is actually a really good one. And I think your challenge, I was in the audience when you asked the question about impact, how do we measure that? And collectively, what impact would we really have if we started working together? So the other issue, I think, for us is leadership. One of the things I'm involved in is the Women Transforming Leadership Programme. It's an executive education programme for women, and leaders, entrepreneurs all come there. And essentially what you're doing is providing a space for people to pause, not to stop, but to pause and to talk and to reflect and learn from one another. And what you get with those conversations is an incredible confidence and also an understanding that people lead and be entrepreneurial in many, many different ways. So it's about convening those spaces of conversation for you to explore and imagine different ways of working. So I think that's some of the things I would start with.
Before moving on to the bigger question, Jan, I can't help asking you about the college role in this. If you see a college role in this, because this is one of the things that sets us apart from other institutions, the fact that we have this strong.
I do see a college role, because I think the college is a great way to bring people together. If you're in a vast amorphous university, then it's more difficult to bring people together. And I think because of the interdisciplinary nature of colleges, each college is a brilliant microcosm of the world, bringing people together to discuss different things. And over dinner, you might have a medic sitting next to an engineer who's talking to a social scientist, and you think, that's the way forward. And I think that to have a chair in women's health would be amazing, but just to have masters in women's health would be fantastic. And to have that embedded in a college or two, I think that could really, bring about good progress.
So what's stopping us having a master's in women's health?
Nothing from my perspective. And can I make a plug here? No, it is a great question. And so we have at some of the Oxford India Centre for Sustainable Development, blah, blah, blah. But we've got 19 fully funded scholarships now for young people, masters and DPhils from India, And we've got one young woman at the moment who's just starting a DPhil on defecation, which defecation in India is absolutely paramount. If you can solve that, then you're helping women in health. So we can spread it wider. So who can organise a women's health masters? Somebody in this room can.
Any volunteers?
Robin.
Well, we put it out to people earlier that Stephen and I think we should have a master's in women's health. So, anyone who wants to help us,
be amazing.
Could I just add to that? I think another thing that's worked extremely well in this university is these doctoral training centres. Yeah. And so I think at the next call, probably next year, welcome, wherever, etc., we should work together to put in one of those applications, get 20 students, and they'll be working across all departments, all divisions, etc. That's a way of gluing us all together.
There is also a mechanism, because we introduced it in my first year, the new and innovative courses mechanism. So you can put a proposal to the committee on which you and I I've realised now, of course, this is Oxford. We have since created a subcommittee to do the actual technically, I think you and I oversee this. And the whole idea was to encourage new programs, because with just the constraints we feel on, or the colleges in particular feel on growing, the difficulty of growing, we wanted, departments were feeling stultified, we wanted to encourage innovation. So we've created this new mechanism for new and innovative courses. So if people were prepared to put the effort into it, it's helpful. We could really put it on its way. So let's move a little beyond ourselves for a minute, although I know our question is focused on ourselves. But Jan, what are some of the important issues you think we need to address? You just mentioned one of them, but if we're committed to reducing inequalities in healthcare for women and girls outside the privilege.
Outside, I think that I like this Sustainable Development Goals because I think that they apply to the whole world, and if we can bring about change in that way, that would be wonderful. So you've got Sustainable Development Goal, which is about health, SDG 3, great, but you've also got SDG 5, which is about discrimination against women. And I would suggest, unless we really act on that Sustainable Development Goal, get rid of discrimination against women, get rid of violence against women. 1 in 5 women in developed countries are subject to domestic violence, 1 in 4 in the developing world. If they are, especially in the developing world, subject to to domestic violence, I mean, it's physical health, mental health, they can't work, it affects the family. So I think that if we could really do whatever we can to help, and it's not just about the women, it's about educating the men. I went to a fantastic couple of projects in Pakistan where it was a group of women and men who were working with men in the community to enable men to understand if they could use their power in order to empower their women and understand that they should not be violent against them, and it brings dividends. And I just think that if we could get gender equality, including in politics. I mean, I'm a sort of part-time politician, and only I think it's 23% of elected politicians are women. It does make a difference if you've got women in politics. And because in India, for example, I go back to India, they've got fantastic rape legislation. Is it implemented? Oh my God, no. In this country, 3.3% of rapes which are taken to the police, only 3.3% are actually prosecuted. Well, hell, you know, we've got work to do all over the world. Sorry.
Anything you'd like to add to that, Sue?
It sounds, I mean, I guess in the business school we focus on a little bit about what we do. We're very much trying to encourage entrepreneurship. And the Oxford Foundry, I don't know if any of you are familiar with the Oxford Foundry in George Street. We've set up, the second year it's been running, is a kind of course for about 8 women entrepreneurs from the students from the university, and that's been really successful in terms of helping support them to imagine and be curious about these entrepreneurial projects which then spin out. So if nobody knows about that, it's a really interesting model, which the invitation is to get involved in that. We've just had, we've got a new chair of our school board, Paul Polman, who you know is I hope he's wonderful, because he's chairing our school board, so we'll see about that, but yeah. But he is very good, and he said his first meeting, he reminded us, I've written it down here, that if women were given true equality in all countries, the amount of capital that would create would be enough to achieve all the UN sustainable development goals. So that is you know, really interesting to think about that issue about inequality. I think Sarah mentioned that notion of how do we make progress on inequality has to be at the heart of anything that we do in Oxford, and we're well placed to have that discussion.
Do you have anything to add?
Not really. I guess the only thing from the engineering point of view contributing to that is engineering is often behind the scene, is just a lot of the drive, particularly in healthcare technologies, is about affordable healthcare technologies. So it's about addressing inequalities. So it's that underpinning of how you address inequalities in general. And it's maybe a little bit more behind the scenes, but I think as things progress, that's a very important direction of travel. And relatively new as well as a topic that people latch onto.
So Chaz, you were in the pharmaceutical industry for many years. Why is it that so much of their research assumes women and men are the same, and so the treatment for women ends up being inadequate or wrong because the assumption is the human is the male human?
I mean, it is absolutely crazy, and I can share with you, Louise, I think around 2012, I sat on an NIH strategy board. So they had a 2.5-day meeting in the US, and it was basically to come up with a new strategy for research in women's health. And for 2 days, we heard about there are many diseases that are more common in women. Rheumatoid arthritis, migraine, irritable bowel syndrome, fibromyalgia, etc., etc. We also heard from clinicians that, you know, the dose response for some drugs is different in men and women. And, you know, the other day, Cecilia's not here, but just a couple of days ago, oh, there you are, Cecilia. Yeah. Cecilia gave a wonderful presentation, and she was talking about sort of, adipocytes in females and males are different sizes. You know, the female adipocytes are smaller. I mean, so the data is out there. There are big differences. There are pharmacological differences, there are physiological differences, anatomical differences, etc., etc. And it's crazy that we almost ignore it, actually. And the reason I was obsessing earlier about outputs and impact, because I was sitting there thinking, we had this discussion, 7 years ago. What difference has it made? We're still doing the same stuff. And so I think we do need to change it. And in our own space, Stephen, we all talk about precision medicine. So the idea is that if you take any common disease, take Alzheimer's, it's actually not one disease, it's probably 10 different diseases. So what we need to do is understand each subtype and basically get precise treatments for each of those subtypes. But you could argue that the easiest way of breaking up sort of the patient group is men and women. There are big differences, and we're not doing it.
So what would it take to change this?
Well, I would love us to, and Steve and I can do this, Robin, and sort of, we can produce a pipeline of targets. I'm looking at you, Ahmed, which are focused on new targets. New targets for some of these diseases associated with women's health, etc. And we can create that pipeline fairly quickly. I think let's aim to generate molecules and let's aim to test them in patients. Let's test them in women, and if appropriate, even test some of them in men, and really publish that data.
So traditionally, pharma has shied away from women's health. That's the basket. It goes beyond what I was trying to be saying. Investing in new therapies, specifically for women, is not something pharma really has ever been interested in doing. Right. In part because they don't see the size of the market being large enough, in part because of fears of reproductive tox. You know, the thalidomide disaster has really been one of the major barriers. So is pharma, do you think pharma's still in this headspace?
I don't think so, Stephen. I mean, I think we need to be careful not to sort of criticize each other. I mean, I think we just have to accept that these pharmaceutical companies, they're private organizations. In general, they're going to focus on areas that are big commercial opportunities, where they can get a return on investment, where they're least risky, etc. So I can tell you at this NIH meeting, fibromyalgia, there was a discussion that, we need to develop an animal model of fibromyalgia, but using female rats. And I sat there thinking, we haven't got a clue what causes fibromyalgia. How the hell are we going to develop an animal model? You know, so I think, you know, inevitably these commercial organizations are going to focus on big potential opportunities, but endometriosis, you heard the numbers, they are big opportunities. Migraine, rheumatoid arthritis, irritable bowel syndrome. I think it's our job in academia to come up with a better understanding of these diseases, to stratify them, to come up with targets, to come up with new biomarkers. Then pharma will jump in, I think.
I'm sure that's right, but that sounds quite long term. I mean, maybe I'm an optimist, and my husband used to call me a Pollyanna, but somehow we've got to change the mentality of pharma companies. I mean, there must be loads of great Oxbridge graduates, alumni, who are now on the board of all these pharma companies. We could talk to them as well.
We can. I mean, I love your passion, Jen. But no, it's absolutely. I mean, that's exactly what we need. I mean, if we don't have that sort of conviction, we won't change it. But, you know, I can tell you, last week I was at a meeting in Cambridge. It was a rare disease meeting. There were 300 people sitting in the audience. And, of course, as you know, there are 7,000 rare diseases. And a lot of these were patient organizations, and they started getting very critical of pharma. And actually, I found myself stepping up and trying to defend pharma because, and I said to them, look, sort of, you take any company like AstraZeneca, of course, we expect them to come up with a drug for Alzheimer's and diabetes and cardiovascular disease and various cancers, etc., etc. They're not going to work on 7,000 rare diseases as well. because they just don't have the expertise, the resources, etc. So I think we have to be a bit pragmatic, and I think rather than sort of pointing fingers at each other, we need to identify what are the strengths of everybody. Everybody's got strengths, and let's bring them together, create win-wins, but I think in Oxford we can show them. Let's come together and let's make it happen.
Well, Greener leads a joint venture with Bayer in target discovery, as you know. That's a really nice model for how we could work.
Absolutely.
And they are, as one example of industry, clearly very keen on working in this area. What about lobbying funding bodies? I mean, NIH was mentioned before. I don't think we do enough with the major funding bodies, Wellcome Trust, MRC, to really bring about funding programs that tackle some of these issues.
Can I ask you to use the micro, please?
Looks as if we've got 6 microphones.
No, my question was, what can we do to lobby the major funding bodies of academic research, really? Wellcome Trust, MRC, NIH, I understand, is already thinking along these lines, but clearly the amount of funding that goes into looking at these kind of issues, that could be a game changer if they actually put that on their agenda.
Again, sorry if I may, I love the GCRF example. Let's come together, let's come up with a plan and say, right, we're going to generate these outputs in 3 years or 5 years, and to do that we need this much money. We will get it.
I think one of the things that's really important in this space is that we need to generate questions that are really impactful, that we can coalesce around. So I think thinking about pushing your initiative on, it'd be very helpful to think about what are the real questions that would unite us to do that and think about that in a very deep way. And I know that wasn't one of your questions on your Mentimeter, but it might be very, very helpful to do that. I think once we've got that, you'll find people will flock, and then we'll have passion to lobby in the way that you're suggesting, I think. That's a good idea.
Well, I think Stephen asked earlier, what are the priority questions?
That's right, you did, yeah. So, more of that.
Patrick Grant's got a new big strategic research fund that's looking for what is going to be, you've got to answer research, what is the universe, what is the next big question? Where should there be a big strategic investment to address something that, that needs addressing in whatever sense? So, if there is the groundswell and the questions and opportunities and the breadth,
To link into that.
I would suggest using that as a target to go, okay, how are we going to get Patrick Grant to give us 15 million quid? I know how much is in that. I think less than 15 million. And I don't think that particular fund is going to be the solution, but it could provide seed funding.
Seed funding for the conversations.
Proposal for a bigger grant. Other questions, comments? Yes, please.
I'm really inspired to hear also your passion and, to me, the underlying resolution for what you guys are saying. Sorry.
The underlying resolution for change is equality. We're a developed country, and yet we still don't have equality in every which way, in pay, in representation, etc., 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 etc. How the hell do we solve undeveloped countries' problems when we cannot solve our own? And how the hell do we make it change?
So can I ask you back, what do you think is the main cause of, I don't think anybody would dispute your description or the underlying point. So what do you think is the main cause of this inequality?
I think it's there from day dot when children are born. You don't see your mothers having equal opportunities. You don't grow up believing that you have an equal opportunity. My mother didn't work. You don't believe that it's achievable. So if it's not there from day dot, family relationship counselling at schools, how to run a family, showing that mums and dads are equal and have equal participation, doesn't exist in many families in the country. That could be part of what happens at schools to understand how to treat people appropriately. It's basic stuff, and if it's not there at the beginning, it's not going to be there at the end.
So how are we going to fix the we can't fix ourselves?
Well, I would say in terms of fixing ourselves. I mean, you know, we've got quite a few problems in this country at the moment. However, I'm really optimistic because of the young people we've got in the room, the young people that we have in the country, the young people at Oxford. I mean, we should be, I mean, we provide them with a fantastic, well, education is much more than that. I mean, the knowledge that they accrue and the confidence in their academic prowess, which is brilliant. But we also, I believe, want to turn them out into the world being really great citizens and good human beings. So I think we've all got a responsibility to do that. When it comes to the developing world, I mean, there are sort of opportunities. If I'm thinking in political terms again, in Rwanda, when they had their new constitution and they embraced democracy, they've got 50-50 men and women. Now, I don't know what difference that has made in terms of the development of Rwanda and healthcare for women. I don't know, but it is interesting, you know, in some countries, if you start at the beginning, it's really quite good. And there are some fantastic things happening throughout the world.
Just to add to that, again, just thinking about some research that we're involved in the business school. I mentioned the Women Transforming Leadership programs. We've interviewed now 200 of these women all over the world about their experiences of leadership, their journeys, what they experienced in the way that you're talking about. And just cutting to the chase, I mean, one of the themes there that's come out is the importance of self-acceptance, that you as a woman can make a difference, yeah? And we're talking about this in the context of leadership. So I think we need to help people imagine possibilities in some way. So I think that's important. And then the notion of self-management. How do you manage your time and yourself and your career, but also self-development? How do we provide coaching, mentors, and all the rest of it? So, but I think that's really quite an important thing, this notion of getting people to imagine different possibilities, even when you might come from a place where it's difficult to do that.
I suppose, could I just add, I mean, I think we need to be careful collectively that we don't try and boil the ocean. I mean, no, we realise that there's lots of things that need sorting, etc. Let's just focus on 2 or 3. Let's get some success, and then success breeds success. So in my own space, Stephen, with yourself, Ahmed, etc., if we came up with a new molecule and showed it worked in women and not in men, it would transform the industry. We have to lead by example.
I mean, I think there's
You should know Ahmed is an incredibly smart guy. He's a very modest guy, but he's incredibly smart.
And he's going to sort everything out for us.
He is, absolutely. This is why I always want to work with him.
So, just that, thank you. So I think actually now is a great time because of the new technologies, the presence of new models that we can use for, such as organoids, new things like microfluidic systems that we didn't have in the past. And, you know, we have single cell sequencing facilities that we can throw at some of those problems and look for discrepancies between organization of tissue, same tissue in male and female, and look at, and then obviously small molecule screens that target proteins that may be very differently organized in different tissue between women and men. So I think that these are things that are actually can be done.
And it's all in our control. Yes. And if in 5 years' time we've not done it, we need to blame ourselves.
Could I perhaps come back to something that when we started off this morning, and perhaps Louise addressing what can we do now? Stephen referred to the British Heart Foundation report that came out that showed 8,000 women likely died over the last 10 years because they weren't receiving the same quality of care as men were receiving. Now, what should we do about that? I remember when the paper was published at the end of last year, the final comment was, oh, well, we should talk to people about it. And I thought, no, this is where we need to work with our social sciences to do that qualitative work. Sue, you would understand, to know what was going on with the clinicians in terms of why were they, what was the conscious or unconscious bias that was happening at that time with the clinicians? what did the women think were happening at that time? You know, that is just so startling. I haven't read the report and to see what they think they're going to do, but I do remember seeing that end of that paper. The other thing I just want to come back to is I think Katrina, when she talked about the range of issues around women and water, and I think what struck me in what you said, more than anything else, is we still don't know enough about this. You presented some examples of the ranges in which women, water and health are related, but mostly you kept saying we don't have enough data. So, and we're not thinking about solutions, we're still describing the problem. So I'm just presenting some other, perhaps at a different end of the spectrum to the molecules that we might want to consider.
Thank you.
But
very patient person at the very, very back. And who's been trying to get, actually, there's the woman behind. Yeah,
Hi, my name is Sanya Pasetta. I'm a professor of modern history. I work on women in Ireland and Britain, and I think the humanities have a huge role to play in this, in ways I think that perhaps aren't being considered. But one thing I'll just say with apologies to particularly Jan and Louise, who are bored, I'm sure, by hearing about this. Next year is the centenary of women's formal admission to this university. That seems to me to provide a golden opportunity for fundraising and for also looking at our women alum. We've done some of this for our work on the centenary and the suffrage centenary, and there is a huge enthusiastic market out there of women graduates in particular who want to see Oxford doing more for women.
Thank you, Sanya. You've stolen my...
So my name is Cecilia Lindgren. I'm at the Nuffield Department of Women's and Reproductive Health. So I think the discussion is really interesting, and it crystallizes to me that, you know, and I think Chas has touched upon it, and we have discussed that funders today want to see interdisciplinary research. We're all excited about it. We can see the necessity of it, but unless we can sort of come together around particular question with a defined success, in my experience, interdisciplinary research is really difficult, super exciting, but really difficult. So I think we really need to be crisp about the narrative and which questions we address and how we will know if we succeed. So I can see several parallel strands, like the biomedical one, which Amit was touching upon, which many of us are interested in. There is the public health questions, which we're all equally excited about. There's the e-health that Robin and Alison have sort of touched upon and so forth. So the question for me is how we interweave it sort of between the different sort of layers and retain the crispness, because that's not trivial. And I think that's one of the key obstacles I can see for having defined success in the outcome. And if I was a funder or a philanthropist, I would want to understand that before I put money on the table.
Thank you.
I totally agree, but I think what's more important is, and having sat in these sort of meetings probably over the last decade, is that we've now gained so much experience in forming these groups. I think I feel quite confident you can find the way forward and work towards that, and potentially quite quickly. And I think there's lots of people in the room who've got shared experiences as well. Whereas if you were talking 10 years ago, you'd be much more earlier in having a conversation about how you would approach this. So yes, it's really hard to form a new interdisciplinary consortium, but we've got experience of bringing certain groups of people together. I think what's exciting is about bringing people who haven't done it before in as well, and it's when you do that that it makes a big difference.
So, I mean, Cecilia, I completely agree with you, but if I can just go back to Robin's example about the BHF. So there is an example where we've got data, but we've not converted that data into a policy change. And Jan and I have been involved in a similar discussion with Raymond Tweck. Again, we've got clinical data and we're not converting it into policy. And those are, I think, could be shorter term wins, Jan. You said what I was saying was too long term. No, but that could be a shorter term win. So I think we need to focus on the questions and we need to focus on the outputs, and then we'll get the grant.
I was thinking if we could have one question that would be kind of the common question to be addressed from humanities, from sciences, from all of us, so that what is one practice or one practice that you think will change women's health? And then we will all address that question. I've just offered one question. We will all address it in one paragraph, 2 paragraphs, and we would just have a document with the different answers to that very same question, which would be then followed by also what is needed to answer that question. So in my case, I think from the humanities, and someone else mentioned before, we are good at understanding the practices. We are not that much interested in the data, I'm sorry. I mean, if data are fine, but we want to know what the practice is, how the data are entangled in the practice. So it's just, some others are more interested in the data. What I want to say is that if we just have one question, which is, what we think will make, what is the practice that will change women's health? And then we just answer from different perspectives.
I mean, I think it's a really good idea about generating a dialogue, and then also you'll pick up what your real interest is. And I think it's important to be really honest about that. In my world, we're interested in what aspects of context shape behaviour. So we would be very complementary, and I think that's the kind of dialogue that we need to really play to our strengths, as well as remembering we are incentivised in different ways, and we need to appreciate that as well.
One of the things I think about in trying to confront the various very real problems, like the one we're addressing now, is how do we as an institution balance a focus on real problems that we want to solve and the thing that we and we alone can do, which is curiosity-driven research. And if you think about so many of the great inventions, whether it's computers or electricity or you name it, so many of them have been discovered by people who had no interest in their practical application. So how do we as an institution manage to balance the nurturing of both of these? I think it's a non-answerable question, but I ask myself, I'd welcome any advice on that.
I suppose in a way it's horses for courses as well, isn't it? Because I mean there are some people in our university who are doing research for curiosity's sake. I mean knowledge for knowledge's sake, as it were. But there are other people who are finding answers to things, and we need the blend of both. And maybe that's what we've got.
Yeah, I mean one of the things that we've started to think about with my academic colleagues is that in management studies, people fall into the curiosity or they fall into the practice. So actually pairing them. Is actually quite interesting. So they mentor each other and they're asking difficult questions of each other, and that's been quite an interesting tension that has yielded some quite impactful research. So I think that might be something. So I guess it's sharing ideas like that, but that's beginning to work for us, just recognising people's interests but pairing them and almost mentoring each other in a different kind of way.
Yes,
what Stella was saying about what we as humanity have decided our priorities. But we've set those priorities through the United Nations Sustainable Development Goals. And aligning the strategy of the university, I think, with the SDGs would be one good way of moving forward. It was so nice to listen to the 1 million women study. We are on target to miss the maternal mortality rates 2030 by 1 million women. That's 1 million women who will die. 2.5 million babies every year die, and that's not just an individual tragedy, but also if you think about the potential that each one of those human beings has to transform the world. Any one of those children could be a Greta Thunberg of the future, or whoever. So let's just think, I think just about molecules, but also about strategically aligning ourselves with those big picture numbers as well. Thank you. Yes, it's not special pleading, by the way. I do perinatal epidemiology, so conflict of interest statement.
Yeah, I just want to add that
fully agree with what you just said. I think if we really align our work with the SDGs, it will be a very good way to position the institute. And also, I think that we need to be very careful with this. What matters for this institute, I believe, is to really identify what the gaps are. Because sometimes, we have the knowledge, sometimes, right? It's not just about generating new knowledge. Sometimes we know what needs to be done. It's just a matter of doing it. So sometimes, we have some knowledge gaps. Sometimes we have the knowledge, but we have implementation gaps, right? So to me, one of our work here would be to really identify what the gaps are and see exactly how we can really fill those gaps. And also another thing that I want to add is really advocacy work. Because sometimes the knowledge is there, but getting that knowledge out and translating it into policy is really a big deal. So those are my comments.
Thank you very much. Well, I think we are out of time. And as I look at the question we were asked to answer, how can we enhance transdisciplinary collaboration across the university to improve the health of women and girls around the globe? I think there's real agreement on the problem. I think the approach we've heard is that the way to deal with this is to focus on solve particular problems and then grow out from them. But the best way of doing that is bringing together people from different disciplines. The advice we've gotten is that we should use the Sustainable Development Goals as a lodestar as we plan our work. And then we have the very practical advice that we use the 100th anniversary of the matriculation of women at the university, either to introduce a Master's in Women's Health or a CDC. And we've had lots of good other suggestions along the way without perhaps as definitive an answer as you would like. But with that, can I ask you to thank our panelists?
Could I just thank the Vice-Chancellor for her support and the panelists. And could I thank, I know some people have left earlier, but could I thank all of you for coming, for your enthusiasm and for your commitment to trying to improve the lives of women and girls around the world. Can I just make a couple of observations, picking up on some of the things that people said? First, this is not a biomedical problem alone. The reason for women in rural India being thin and anemic has got nothing to do with medicine. And that's why a transdisciplinary approach to these problems is so important. And second of all, is that the panelists really shied away, I think, from a really important question about the role of a university like Oxford in the 21st century. Getting my paper into Nature is not enough any longer. It's not enough if your commitment and your passion is about improving the lives of women around the world, because they certainly don't read Nature. And lastly, we have in this university some of the brightest minds on the planet, okay? And when we first went to see the Vice-Chancellor, she made an incredibly important statement. If we, as a university, can't do this, no one can. And to have the support of her and other senior members of the university, I think, is incredibly important. Raising money, by the way, is easy. I don't think that raising money for this initiative is going to be difficult at all. With the help of Louise and the other members of the Central Development Office, we've already started approaching potential donors. That's not the problem. The problem is what we focus on together across this university. That's what we need to work on. Anyway, thank you. As always, I forgot something. Do you mind just staying up a few more minutes?
All right, so these are the results for the first question, where we asked each of you to input 3 words that described your specific interests in women's health. As you can see, mental health, pregnancy, health inequality, life course, and contraception were some of the more popular entries there. But we really have a broad spectrum that really touches on women throughout the life course, which is one of our words. I see things like aging, and I also see a very broad variety of disciplines listed. Everything from economy to history to big data is listed in here. So these are the results to what would a women's health at Oxford portal include. So again, a portal that's modeled off after the AFOX model. And basically all the suggestions were quite popular. So I think we'll try to do something that incorporates all of these. So those are a searchable database of Oxford women's health researchers, opportunities to get involved, so vacancies, fellowships, research funding, and communication of Oxford research achievements. What kind of women's health at Oxford events would you be interested in attending? Again, a lot of popularity for all of the choices. So those were transdisciplinary seminar series, networking events, and knowledge exchange opportunities between researchers and policymakers, implementers, and our patients. So really connecting the research we do here to the outside world and making sure that we have an impact. So this is very encouraging. So everybody wants to get involved, that's great. So we will be in touch. We're very glad that you're still interested after we presented the vision, and you know, we will be incorporating a lot of the feedback we've heard today moving forward. And that's it.